Welcome again to the Innovate podcast. Subscribe, remember to hit that like button, and let's dig into today's session. So, today we are going to be sharing with you an introduction and an overview about pharmacokinetics. I'm Joseph Lusuavi, and I'll be taking you through this session. So, pharmacokinetics, we are going to begin by just reminding ourselves of what we actually previously saw in the previous episode, and this is something that was done. So, previously we have looked at the forms of drugs which we saw in the solid, semi-liquid, and the liquid state. We also appreciated the routes of administration, where we had the oral or the enteral, we had the parenteral route, we had the topical route, and then also the inhalation. Now, in your mind, you need to ask yourself, what happens to the drug when all is done? You have taken in maybe a solid drug. It has been taken in the oral route. So what next? So how does the drug move to where it is actually destined to go? Second, where does it go after? Third, does it stay in the body forever, or it is eventually removed? Now that is why we are discussing pharmacokinetics. First of all, pharmacokinetics, you need to appreciate that it's what the body does to the drug. So let's say now for this scenario, a medicine is going to be taken in the oral route. If it is taken in the oral route, the first thing that needs to be known is actually how will it get in. You've taken it in, now you need it in the body. How will it get in? So that is now where we see absorption. Then after absorption, the other question is, where will it go? Where we see the distribution, and there it requires probably transporters. Then after that distribution, the next question is, how is it broken down? Where we shall see metabolism, which normally takes place in the liver, and then the excretion, how the drug will leave the body. Appreciating the definition of pharmacokinetics is very key, and we said there are 6 key points. First is a branch of pharmacology. Second, we are looking at the mathematical description. Third, we are looking at changes in drug concentration, where in the body, over what time, and then the processes that are responsible for these concentration changes. When I combine each and everything, we would say that pharmacokinetics refers to the branch of pharmacology that deals with the mathematical description of changes in the drug concentration in the body with time and the processes that are responsible for these concentration changes. Now, as I've shared with you previously, we are going to look at a drug being administered. This drug could probably go through the oral route, or it could go through the intravenous route. When it goes through the oral route, it is going to undergo some breakdown, and then some drug will not be available, where we see the enteric metabolism, and some will now go through the enteric transportation. It will undergo enteric transport. When it is transported, it will now go into the liver, then it will be delivered to the heart, where it will now be distributed into the intravascular spaces and also the extravascular spaces, and that is with the help of the protein binding. Now, after this drug has reached the areas or destiny or the target tissues, it will now undergo metabolism. Metabolism, we are going to focus at it actually being broken down so that it can be easily eliminated out of the body. That will normally take place, in the liver, and we have 2 phases, phase 1 metabolism and phase 2 metabolism. After that, we are now going to have the drug being excreted. We shall have biliary excretion, we shall have intestinal excretion, we shall have renal excretion. Here we are looking at bile, we are looking at urine, you are looking at also feces. Now, my colleagues that will come after will actually expound more onto everything that we've just said. For now, we are just giving an introduction and an oversight. Now, pharmacokinetics will take place in the 4 explained processes, as we've seen in the previous. If you've realized, we are all explaining the processes that are going to affect the drug concentration within the body. And these are basically 4 processes. Now, here, allow me to actually just give you an oversight. Now, the rest, as I said, will now dig down into more. The first process will now be the absorption. So absorption, here we are looking at basically, it is more or less, someone would say, blood entry. A drug is being administered from wherever it is. We are looking at how is it going to get into the circulation, systemic circulation, without any chemical alteration. That is absorption. The next after absorption is distribution. It has now moved in. Now you expect it to reach the target tissues. So the journey of the drug through the bloodstream to the target cells is the distribution. The next is now metabolism. It has finished, it is done with, maybe impacting the tissue of its concern. And now what next? It now has to be modified and rendered inactive, which is metabolism. With this, it will ease its elimination from the body. After its ineffectiveness by the enzymatic reactions, then we expect this drug to be actually moving out of the body. So that is now excretion, and that would basically refer to how the drug is removed from the body through urine and feces. It's very important to note that drugs must cross several membranes to be absorbed to reach the site of action. That is for the GIT condition treating drugs, because those will also still cross the membranes and enter into circulation. We also have those drugs for IV, which will have to actually cross capillary membranes to leave the circulation and reach into the extracellular and intracellular sites of action. However, also please note that not all drugs need to enter circulation to act. So, pharmacokinetics of drugs is studied by determining the drug concentration in plasma at intervals. And an assumption is that drug concentration in plasma is in equilibrium with the drug concentration at the receptors. Now, the rate at which drug reaches site of action will depend on two things. The first one is the extent of absorption. So the extent of absorption, you're looking at how much drug is going to be within the systemic circulation or into blood. And then the extent of distribution, where you're looking at the delivery of that drug to the tissues that is expected to be worked on. Thank you very much for listening. Now my colleagues are going to be coming to now expound on each of what we've talked about in the processes of pharmacokinetics. That is absorption, distribution, metabolism, and excretion. Thank you. Stay tuned.
Hi everyone, this is Jerry Ellison Mutiavale. I'm going to be taking you through drug absorption and distribution. When we talk about drug absorption, what do we mean? This is simply the movement or passage of a drug from its site of administration into the bloodstream, whereby the site of administration can be oral or parenteral, that is through injection or inoculation, and that drug passes into the bloodstream. And it is the first step that the body takes to begin processing a drug, i.e. pharmacokinetics, which simply means what the body does to the drug. So what the body does to the drug, absorption is the first step. In order for absorption to occur, a drug must be transported across one or more biological membranes in order to reach blood circulation. Yeah. And we are going to look at those different ways. Now let's look at the mechanisms of drug absorption. The first mechanism is simple passive diffusion. Just like the statement goes, simple, it's a simple mechanism. Passive, it doesn't require energy. And diffusion, which is simply the movement of molecules from a region of high concentration to a region of low concentration. So, under simple passive diffusion, the concentration gradient across the membrane determines the absorption rate. The higher the concentration gradient, the higher the absorption rate. Diffusion also depends upon lipid solubility of the drug. Since the drug is passing directly through the membrane or across the membrane without the need of energy, its transport will depend on its solubility through the membrane. Because remember, cell membranes are made up of a lipid bilayer, by which lipids are hydrophobic. So, for a substance to pass through, to diffuse through the bilayer, it must have a high lipid solubility. The second mechanism is active transport. Yes, just like the word active is, it requires energy. So it is an ATP driven process, and it is independent of the concentration gradient. So it is simply the movement of molecules across the membrane using energy but against the concentration gradient. We can see this in the renal tubules, the bile duct, the blood-brain barrier, and the GIT. The third mechanism is referred to as facilitated diffusion. We looked at diffusion, which is movement of molecules from a region of high concentration to a region of low concentration. Facilitated, that means it is being helped by something. So what is helping it? Carrier molecules are used. So under facilitated diffusion, we have special membrane proteins or transmembrane proteins called carrier molecules, which are specific for specific molecules that bind to them, and they are transported into the bloodstream. So these carrier molecules may undergo saturation, stroke competition, and drug-drug interactions. So this is where, if a carrier molecule is fully occupied, that is what they call saturation, all the sites for binding of the drug have been occupied. So it can be saturated at a given time, regardless of the concentration of the drug administered. And it can also undergo competition, that is drug-drug interactions, whereby certain drugs that use the same carrier molecules tend to compete for those transport proteins. And all this affects the duration and intensity of action of the drug. So we can see in the diagram below, this is simple diffusion, whereby our drug molecules are moving from a region of high concentration to a region of low concentration without the need of energy or any carrier molecules, and that is simple diffusion. We have facilitated diffusion, where the molecules require carrier molecules to transport them across the lipid bilayer or the membrane into the bloodstream. We can see this, these triangular looking molecules, which are specific for their own carrier molecule. And we can see these round or circular molecules, also being specific for their own carrier molecules. So this is facilitated diffusion. Then we have active transport, where we require an ATP molecule to bind to a carrier protein or molecule in order to facilitate the transportation of drug molecules across the membrane. So, to go further into detail, there are other mechanisms of transport of drugs that may not be mentioned, but I'll go through them briefly. So here we shall have our absorption mechanism, the drugs absorbed. Then we can see here, this is our gastrointestinal lumen. This is our gastrointestinal lumen. This is the membrane that the molecules are going to pass through in order to enter the blood stream. So, the first mechanism, as we saw, passive diffusion. What are the drugs absorbed? Most drugs having high lipophilicity and a molecular weight in the range of 100 to 400 nanometers. So, lipophilicity, meaning they are lipid soluble or lipid loving. So, those are the drugs that will be able to pass through the membrane by passive diffusion. Another mechanism is power transport. Power transport, here we have water-soluble drugs of a molecular weight less than 100 nanometers. So for power transport, it's used by these water-soluble drugs because they can't pass directly through the lipid bilayer of the membrane. Another mechanism is the ion pair transport. Just like the name states, it's an ion pair, and it's used by drugs that ionize at all pH conditions and are absorbed after complexing with oppositely charged ions. So ion pair, a pair consists of two parts or molecules. So we have certain drugs whereby under all pH conditions, these drugs tend to become ionized or charged. So such kind of drugs require another ion of the opposite charge in order to make them inert or lose the charge. Yeah, you can see these are our two pairs of ions. One can be the actual drug that is going to be transported, then the other is the other molecule that the drug can bind to in order for it to lose the charge and therefore be able to be transported across the membrane. So that is called the ion pair transport. Another mechanism is carrier mediated transport, which simply is our facilitated diffusion, where the drugs involved are structure specific drugs with affinity for carriers transported from specific sites. So we can see this drug molecule being structure specific to the carrier molecule. So when it binds to the carrier molecule will translocate it across the membrane into the bloodstream. Then lastly, we have endocytosis, whereby macromolecular nutrients and drugs as solid particles or oily droplets. So let's move on further to the factors affecting drug absorption. What are the factors affecting the way these drugs are passing to the bloodstream? One of them, we have lipid solubility of the drug. We find that drugs with a high oil to water partition coefficient. What does that mean? A high oil to water partition coefficient. That means these drugs are more soluble in lipids or oil compared to water. Then, if it is a high water to oil partition coefficient, that means the molecule is more soluble in water compared to the oil or lipid. So in this case, drugs with a high oil to water partition coefficient, meaning they are more soluble in lipids, easily cross membranes, hence greater absorption. And since we've seen that the membrane is made of a lipid bilayer, and these drugs have a high oil to water partition coefficient, that means they can easily pass through that lipid bilayer, since they are highly soluble in the lipids. Yes, another factor affecting is molecular weight of the drug. So we've seen lipid solubility of the drug. Now, molecular weight of the drug, only molecules of low molecular weight can pass through pores. That is, aqueous pores, which are 0.4 nanometers. So that means the high molecular weight drugs are not able to pass through aqueous pores, which are only 0.4 nanometers in diameter. Another factor affecting drug absorption is polarity and charge of drug molecules. So ionized or charged compounds or molecules are not compatible with the uncharged lipid environment in membranes. We know that the lipids are uncharged, so the lipid bilayer in membranes is uncharged. So these ionized or charged compounds, or in this case our drug molecules that are ionized or charged, are not compatible with the lipid bilayer. So that means they are not able to pass through the lipid bilayer since they are ionized or charged. Then the hydrophobic tails of the lipid bilayer also repel polar molecules. So that is where we are seeing also polarity coming in. So these molecules that are polar tend to be repelled by the hydrophobic tails of the lipid bilayer of the membranes. Another factor is presence of carrier molecules. So these carrier molecules simply facilitate the transport of large lipid insoluble drug molecules across cell membranes. So this is where we have our polar molecules, let's say, or our charged or ionized molecules that cannot be transported across the bilayer simply because the bilayer is not charged, so it repels them, or they are polar and the hydrophobic tails repel them. So the carrier molecules enable these lipid insoluble drug molecules also to pass across the cell membrane. And also these drugs that are large or have a high molecular weight and can't pass through the aqueous pores. are also transported using these carrier molecules. Another factor is pH of the compartment where absorption occurs. How does this affect absorption of drugs? Basic drugs are not well absorbed in acidic environment. Yes, we know that there are basically two alternating pH sites, that is acidic and alkaline or basic. So these drugs drugs can either be basic or acidic. So basic drugs are not well absorbed in acidic environment and vice versa, meaning also acidic drugs are not well absorbed in a basic environment. Examples of this environment, let's say in the stomach. The environment in the stomach is acidic because of the production of hydrochloric acid during digestion. Then in the intestines, we have a basic or alkaline environment because of the bicarbonate ions produced. So what happens when a basic drug is in an acidic environment? The drug becomes ionized or charged. So when a basic drug is present in an acidic environment, let's say in the stomach, it becomes ionized. And like we've seen, ionized or charged molecules cannot pass through the lipid bilayer. So it reduces the absorption. And the same applies to the acidic drugs. When they are in the basic environment, they also become ionized and hence cannot pass through the lipid bilayer. So let's look at drug distribution. What is drug distribution? This refers to the delivery of the drug to the tissues. Yes, after the drug has been absorbed into the bloodstream, now we are looking at it being delivered to specific tissues. So in order to be distributed to the tissues, a drug has to cross the endothelial membrane or pores. And the endothelial membrane, this is the membrane, one of the membranes of the blood vessels, let's say in the capillaries, where now we are seeing that the drug has to leave the bloodstream in order to reach the tissues. And this endothelial membrane, just like any other membrane, it is also made of a lipid bilayer. And therefore, many of the factors that affect absorption also affect the extent of distribution. Since the endothelial membrane of blood vessels is also made up of a lipid bilayer. Yes, so some of these factors include lipid solubility of the drug, where we've seen that highly lipid soluble drugs easily traverse the membrane. Molecular weight of the drug, where we saw that low molecular weight drugs can easily pass through the aqueous pores compared to the high molecular weight drugs. Another thing is polarity and charge of drug molecules, which we explained. Then in addition, the degree of protein binding and the extent of blood flow to the organs also affects drug distribution, as we shall see. Drug molecules are transported in plasma as free molecules or bound to plasma proteins like albumin and alpha-1 acid glycoprotein, which process is called protein binding. So why does protein binding, what is it and why does it occur? Protein binding is simply where our drug molecule binds to plasma proteins like albumin and alpha-1 acid glycoprotein. So why does it occur? So they are telling us protein-bound drugs are typically inactive and act as reservoirs, gradually releasing the active drug over time. So these bound drugs, they are inert or inactive. It is only a free drug or an unbound drug that is active. So that means that these bound drugs, they release the active drug over time. And this binding also helps to protect drugs from degradation and clearance, i.e. extending their half-life and therapeutic effects. So when the drugs bind to the plasma protein in blood, they are released slowly, so that means they will have a longer action in the body, which is prolonging their half-life, and therefore their therapeutic effects will also be longer compared to the free form of drugs, whose effect will be short, since they are easily used up and cleared. So they're telling us the bound drug is often in equilibrium with the unbound drug. That means a bound drug can easily transform to a free drug, and a free drug can also become bound. So they are in equilibrium. When the drug is going to take action, it becomes unbound and it becomes free. So only the free drug, as we were saying, is able to cross the endothelial membranes to carry out its action. So only a free drug can cross the endothelial membranes. The degree of plasma binding will also affect the distribution of the drug. So the more tightly the drug is bound to plasma proteins, the less the distribution will be, or the lower the rate of distribution. So the degree of plasma binding will affect the rate of distribution of the drug. So this is just a simple diagram showing what occurs on absorption and distribution. So like we said, on drug administration, let's say through the parenteral or oral route, the drug will pass into the bloodstream, and when it is in the bloodstream, the free drug is in equilibrium with the bound drug, and we've seen why drugs undergo binding with plasma protein. So the free drug, which is the only form of the drug that can pass through the endothelial lining to carry out its action, will then go to the site of action, e.g. a cell receptor, or it can go and be stored in tissue, e.g. body fat, or it can further go to be metabolized in the liver, in the lungs, or in the GI tract. So after metabolism, let's say from the liver, this drug will then undergo excretion, for example, in the kidney, in expired air, in sweat, or through feces. So the free drug can also go directly into excretion, where it is not used in what, let's say, to perform action, or it doesn't undergo metabolism. So let's look at distribution of drugs to special organs. The rate of blood flow determines the maximum amount of drug that can be delivered per minute to specific organs at a given plasma concentration of the drug. So at any given plasma concentration of a given drug, the rate of blood flow, the rate at which blood flows to the given tissues, will determine the maximum amount of drug that can be delivered per minute. So the higher the rate of blood flow to the tissues, the higher the rate of, or the amount of drug being delivered per minute at a given concentration. Well-perfused tissues, for example the kidneys, which receive a lot of blood and hence receive a large quantity of drugs. Then the poorly perfused tissues like fat receive drugs at slower rates, and also the concentration in fat. So these tissues that are poorly perfused are going to receive the drugs at a slower rate, meaning the concentration will also be low. Yeah, because we've seen the amount of drug being proportional to the what? The rate of blood flow. So the more the blood flow to a given tissue, the higher the amount of drug going into that tissue. So fat may be in, the concentration in fat of a drug, the concentration of a drug in fat may be increasingly long after that in plasma has started to decrease. So when the concentration of the drug in your blood is decreasing already, or it has started decreasing, that in fat will be higher, because remember, the drug takes its time to perfuse the fat and also to leave the fat. So you find that even when the concentration of the drug in blood is low, you may have a higher concentration in fat because the drug takes long to leave the fat. So another specialized tissue is the blood-brain barrier, which is simply the barrier between the vascular system and the brain tissue. So many drugs do not readily enter brain tissue. Why is this? Brain capillaries have tight junctions between the endothelial cells, i.e. there are no pores. So this barrier is supposed to act as a safety buffer to prevent certain molecules from entering the brain tissue. So the main mechanism of drug entry into the central nervous system or the brain is by passive diffusion across the membrane, whereby we've seen passive diffusion will literally depend on lipid solubility of a given drug. And they're telling us only highly lipid soluble drugs can cross the barrier, like we've said. So here we can see a diagram of most capillaries in the body and then the brain capillaries. We can see that most capillaries have pores for passage, that is the water-lined pores or the aqueous pores, but the blood-brain barrier, for it has tight junctions, and these tight junctions are simply there to act as safety buffers, because we all know that the brain is a very sensitive organ. So we are saying that only lipid soluble substances are able to pass through the blood-brain barrier. So this is a tight junction, and these are the brain cells, in this case the astrocytes. Thank you for listening.
Hello everyone, this is Kasada Owen and I'm going to be taking you through the biotransformation or the metabolism of drugs. So what is biotransformation? This refers basically to the enzymatically mediated chemical changes that drugs undergo before being excreted from the body. So this can result either into drug detoxification, which involves the inactivation or reduction in the drug activity, or it can, in rare cases or in few cases, result in activation of a drug. But this may give to products of similar or even greater activity. So in this I mean that a drug getting similar activity like the way it was administered, or even getting greater activity like becoming more activated, and in so doing this usually happens in the process called lethal synthesis, which yields metabolites of increased activity. Examples include parathyroid being done what? Being biotransformed to paraoxone. So the parathyroid acts as the prodrug, whereas this paraoxone acts as the what? The metabolite that is formed of increased activity. So paraoxone is non-toxic, but this paraoxone is a powerful inhibitor of choline esterase. So then the other one, we can have fluoroacetamide being converted to what? Fluorocitrate. Fluorocitrate is a specific inhibitor of the enzyme aconitase. So now I've been talking about a prodrug. A prodrug is a parent drug which is pharmacologically inactive, but this drug is metabolized into the active form when it goes into the body. And an example I've already given that parathyroid is a prodrug. Even here we can have another one like nitobene, which is a dewormer being converted to albendazole. So nitobene is the prodrug and albendazole is the pharmacologically active form that is formed in the body. So what are some of the organs that are involved in biotransformation? We have the main one being the liver, and this one, biotransformation takes place within the hepatic microsomes, which we can call or refer to as the smooth endoplasmic reticulum of the hepatocytes. The other one is the lung. This one usually takes out those substances or biotransforms the drugs that have been given in either volatile, the drugs that are volatile and even those ones that are in a gaseous form. Then we have the gut and the gut wall. We have the placenta, but also biotransformation can take place in the plasma since the plasma contains esterases. For example, the pseudocholinesterase, which acts on procaine, atropine, acetylcholine, and many others. Then some of the enzymes involved in the process of biotransformation, we have oxidases, reductases, hydroxylases, and transferases. And the products of metabolism that are formed are usually water or are less lipid soluble and polar in nature. And this polarity in nature renders the metabolites to be suitable for the carrier-mediated secretion processes, as we shall be seeing in the drug excretion later on. So we have the process of biotransformation. This process basically includes two phases. We have the phase 1 reactions and also we have the phase 2 reactions. So the phase 1 reactions are the reactions that involve unmasking and introducing of the new functional groups to the drug. For example, the hydroxyl groups, the carboxyl, amino in the drug molecules, such that in the phase 2 reactions, these functional groups can conjugate with the conjugants in the synthetic reactions. So, and it consists of reactions that can be classified as oxidative, reductive, and hydrolytic, as we shall be seeing each what happens there. Then we have the phase 2 reactions. Basically, these ones involve the can also be called as synthetic or conjugation reactions. And these basically take place when the drug or a phase 1 metabolite containing the chemical groups which we have seen in phase 1. Yes. So the other thing, we shall start with the phase 1 reactions. We say that basically there are three processes that occur in phase 1 reaction, that is oxidation, reduction, and hydrolysis. And we shall start with oxidation. So oxidation involves mixed function oxidases. For example, NADP, reduced NADP, and cytochrome P. And in this, I try to summarize here for you the process, basically what happens during oxidation. That the reduced NADP is the major enzyme or is the major oxidase that is needed, that is going to act reduce a component in the microsome, which is cytochrome P450, which I have named here A. So in reducing it by adding hydrogen, it will give us a component here, oxidized cytochrome P, and also what? Oxidized NADP. So it will give us, reduced cytochrome P and then this. So this reduced cytochrome is going to react with the molecular oxygen and give us the active oxygen complex. So this active oxygen complex is the one that is going to bind with the drug, and it will give us an oxidized drug plus the cytochrome P and water that are going to be there. So this is an equivalent of water. And examples of drugs that undergo, example that I can give here, I gave one, phenacetin, that is being oxidized to acetoaminophene. So there is a summary of these phase 1 reactions here in this diagram, because during phase 1 reaction, these are some of the processes that occur: hydroxylation, oxidation, and these others. So if there is direct attachment, that is when we are introducing functional groups to the drug. They basically occur in the form of hydroxylation, which can be aromatic or aliphatic. The aromatic one is where we are adding on something like a benzene ring and a functional group, whereas the aliphatic one is we already have there a functional group that we are trying to hydroxylate, adding an OH on it, as you can see here. Then the unmasking is just like we are opening up the functional group to make it exposed. As you can see here, that we had a substance here with a functional group that has been masked, and now here it is being undergoes oxidation to give us the functional group, this red one and this one. So this is the hydroxyl group, and this is the carboxyl group that has undergone oxidation. And here the host also demethylization, as you can see here, the functional groups being unmasked. Yes. So we have the reduction reaction. So this one, it doesn't occur frequently, but occur in drugs which possess disulfide, the azo and nitro groups. So hepatic microsomes can reduce these two, the azo and the nitro compounds, to corresponding amines. So, and this process is basically mediated by the fat in the liver. Examples of drugs I can give is the prontosil, which is an azo dye being reduced to sulforamide, which has antibacterial activity within the body. Then hydrolysis is the next one. So this one is important for compounds that contain ester linkages and amide bonds, and it is catalyzed by amidases in soluble fraction of the liver. Yes. So this is basically the summary of this bio transformation that takes place in the body, as you can see here. That we have the phase, we have the drug undergoing phase 1, that is, it becomes oxidized drug, and then this oxidized drug, which is now the metabolite, will go into phase 2 reaction detoxification pathway, and in here it will undergo conjugation, or what we call drug detoxification. where it now later on be excreted from the body. Or this drug can become a reactive metabolite, that is after undergoing both the two phases, phase 1 and phase 2. And if these reactive metabolites accumulate within the body and they are not excreted, or they don't become conjugated, they will become toxic in the body. So they result into toxicity. Or later on, they will go into conjugation and excreted in the body. Then phase 2 reactions. So this phase 2 reaction, as the area owner told you, that they are also called conjugation or synthetic. They take place when the drug or phase 1 metabolite contains a chemical group, as we said, and also it is suitable for combining with the natural compound that is provided in the body to form readily excreted water-soluble polar metabolites. So these phase 2 reactions require conjugants and transferase enzymes. The conjugants are the ones that I have called the natural compounds that are provided by the body. And an example, we have the glucuronic acid, we have the sulfates, amino acids, and alkyl groups. Example like acetyl, methyl, and other. And example of reactions that take place, we have glucuronidation, we have sulfate conjugation, acetylation, and many others, sulfonation, and others. So the phase 2 metabolites that are formed, they are also known as the conjugates. And for example, we have the glucuronidase, ethereal sulfates, among others. So higher molecular weight metabolites, for them they are excreted basically via bile, but that one we shall be seeing it later on in excretion. So what are some enzymes which we say the transferases that are involved? We have the sulfur transferases, the gluconyl transferases, and methyl transferases. So their name give you the reaction in which they participate. There's sulfur in sulfonation, glucuronidation, and methylation reactions. Yes, this is kind of a summary of still what takes place after a drug coming into the body. If you can see here in biotransformation that it can either occur, result into active drug, where the active drug is converted into the inactive metabolite, and most drugs pass via this. Yes, for example, ibuprofen, but these are humans, paracetamol, and many other. Or the active drug into active byproducts. So these active byproducts, for example, here we give morphine and others. Then, or it can undergo into the inactive drug to active enhanced activity, what we call the drugs, which we defined earlier on. Or the drug to reactive harmful product. This is what occurs in lethal synthesis. And they gave here isonidase to acetyl and so is. Yes. So this is a summary of biotransformation here, as you can see. So a compound or a drug can undergo phase 1 reaction where it will undergo either hydrolysis, reduction, oxidation, and then to form this metabolite 1. If this metabolite 1 formed is polar and water soluble, it will undergo excretion directly. But if it is non-polar and also lipid soluble, it will undergo what? Phase 2 reactions, as you can see here, where it undergoes those conjugation reactions and it will form this metabolite 2. Now this metabolite 2 that is formed, if it is still not needed from the body, it will be excreted. But if it is still needed, it will undergo cleavage and it will go back into plasma. But in most cases, this occurs in the bile, or what we refer as to the intrahepatic saturation, where the drug we need it to make more what? We need a longer duration for it to act. But if its duration now is no longer needed, or its activity is no longer needed, then it will be excreted. Then we have, if this phase 3 results into metabolite 3, which is polar and also water soluble, then it will be excreted from the body. Yes, thank you so much.
Hello viewers, welcome to the Innovates YouTube channel. My name is Mugai Gasen Onamayo, and today I'm going to discuss with you drug excretion in pharmacokinetics. And now, to begin with, elimination, which is the removal of the unaltered drug from the body, and then excretion, which is the removal of the drug after metabolism. Then there are various routes of excretion, of which we have micturition, call it urination, which is done by the kidney, and it is the major route. Then we have defecation through feces, and this one contains the unabsorbed drug and the drug from bile. Then we also have exhalation, which is in the lungs for the volatile drugs. We also have lactation, sweating, salivation, and tears. These ones are just minor. These ones are minor, but the major ones are urination or micturition and defecation. So, micturition, which is the main route of excretion, and it occurs in three processes. We have glomerular filtration, also called ultrafiltration. We have tubular secretion and tubular reabsorption. So the total renal excretion of a drug will be equal to the rate of glomerular filtration plus secretion minus reabsorption. The reason we subtract reabsorption is because we are aiming at eliminating the drug from the body, but reabsorption is taking the drug back into the body. So that's why we subtract. So we have glomerular filtration, which happens at the renal corpuscle of the nephrons. The renal corpuscle is this region, and it consists of the glomerulus, which is a tuft of capillaries, and then the Bowman's capsule. So within this we have a filtration barrier. Then glomerular filtration depends on glomerular filtration rate. In other words, if the glomerular filtration rate is high, more drug will be filtered into the tubule. Then it also depends on renal blood flow, to say that if a lot of blood is flowing into the glomerulus, a lot of drug will also be filtered out of the plasma into the tubule. Then it also depends on molecular weight of the drug. For example, we know that this filtration barrier has the fenestrations in the blood capillaries and also the slit pores. So if something is of a large molecular weight, it will not pass through that filtration barrier, but only those of a small molecular weight will pass through the filtration barrier. Then we also have the degree of protein binding. Bound drugs do not cross the membrane. It's only unbound drugs that cross the membrane. The reason being is that proteins have high molecular weight. So if a drug is bound to a protein, in other words, it will not go through the membrane easily because it is bound to that protein. But the unbound one, which is not bound to the protein, it will freely pass through the filtration barrier. Then glomerular filtration also depends on plasma concentration or bioavailability. The higher the concentration of the drug in plasma, the more drug that will be filtered into the tubule. Let's look at tubular secretion and tubular reabsorption. First of all, tubular secretion. This is an active process, and it is responsible for the transport of protein-bound drugs, and it is non-specific. For example, there are only two mechanisms, one for transport of organic acids and another for organic bases. So since it is non-specific, it brings about competition between drugs. For example, acidic drugs, these organic acidic drugs will compete for the same channels, and so will the organic bases will compete for the same channels. An example of that competition will be phenylbutazone will inhibit secretion of the penicillins. Then there is also saturation of these channels, whereby there can be a maximum rate of tubular secretion. Examples of drugs we have penicillin. Then let us look at tubular reabsorption, which occurs mostly in the distal convoluted tubule, unlike tubular secretion, which occurs mostly in the proximal convoluted tubule. And tubular reabsorption is a passive process. It doesn't depend on energy, but it depends on urine flow rate. Example, if the urine is flowing faster, the rate of tubular reabsorption will be low, but if the urine flow rate is slow, then we shall have a lot of tubular reabsorption happening. It's also dependent on drug concentration in the filtrate. If the drug is a lot in the filtrate, a lot of it will be reabsorbed into the blood. Then it also depends on lipid solubility and degree of ionization. For example, since it is a passive process, drugs that are highly lipid soluble freely pass through the cells of the tubules into the peritubular capillaries. Then also ionization. We know that ionized molecules require specific channels for transportation across membranes, but this tubular reabsorption is a passive process, so only unionized molecules will be able to pass through. And tubular reabsorption also depends on the pH of the urine. First of all, pH of the urine will affect the dissociation of these organic acids or bases. For example, if the urine is slightly acidic than normal, meaning we shall have many of these organic bases dissociating. So we shall have them ionizing, in other words, and they won't easily cross the membrane. The same goes for acids. If we have this urine pH slightly rising, we shall have these organic acids ionizing, and then they will not be able to cross the membranes. That was all for the renal excretion. Now let us look at defecation. Defecation is simply the passing out of poop. And drugs that are eliminated via this route, we have the unabsorbed drugs, and we also have the drugs that come along with bile. And those drugs that come along with bile, we have the organic acids, we also have the organic bases, the lipophilic drugs, and steroids. Then also, these drugs are of a high molecular weight. They are of a high molecular weight, meaning that they couldn't be excreted by the kidneys, and the other favorable route would be the liver through bile. Then we also have drugs which are conjugated. For example, we have these drug glucuronides. They come along with bile also. Now, when this bile comes into the intestines through the bile duct and then the duodenum, then ileum, then these drugs, the conjugated ones, when they reach here in the intestines, they will find the bacteria, and this bacteria produce an enzyme known as beta-glucuronidase, and this enzyme will lead to hydrolysis of this conjugated drug, and it will release the drug. Then the drug can be reabsorbed into the intestines and then into the bloodstream, and then it will go via the portal vein back to the liver, a phenomenon known as enterohepatic circulation. Then so the drugs that may have high concentration in bile include erythromycin, tetracyclines, and ampicillin. Now that we've looked at the main routes of drug excretion, let us look at some of the other routes of drug excretion. One, we have exhalation, which is basically excretion via the lungs, and drugs that are gaseous and volatile liquids, such as the general anesthetics, are excreted via this route, and it depends on partial pressures of the drug in blood. And there is also a rapid exhalation of these drugs just because of the close proximity of the alveolar space and the blood in the capillaries. Then there is excretion via milk or lactation. This is only possible in lactating animals. So these drugs enter the milk by passive diffusion, and that means that the drugs that are more lipid soluble and less protein bound have high chances of crossing into the milk better than those that are lipid insoluble and more protein bound. And then it has been found out that the concentration of basic drugs in milk is higher than in blood leaving the mammary glands. This is because the pH of milk is slightly more acidic than that of blood. So these basic drugs will be attracted to the milk, and once they are there in the milk, they will ionize, and when they ionize, they will not be able to go back into the blood. They will not be able to pass via the membranes. Then it's important that when you are going to inject an animal with a drug or to administer a drug to an animal, you should know that you should put into consideration the milk withdrawal periods to protect the consumers from the toxic effects of drugs, and also to protect the young one from adverse effects of the drugs. Then drugs could also be excreted through saliva, but basically these drugs that are excreted through saliva will meet the same fate as orally administered drugs. Well, that is all I've had for you today. Thank you for listening to me.
Ms. Kazulo Patrick, a member of the Innovate, and today I will discuss three of the pharmacokinetic parameters: bioavailability, bioequivalence, and volume of distribution. So simply, these parameters are used to determine the rate and extent of ADME. What I mean by ADME is just the pharmacokinetic factors where we have absorption, distribution, metabolism, and excretion. Now we need to understand bioavailability. So bioavailability is simply a fraction of a dose of a drug that is absorbed from the site of administration and reaches in an unchanged form to the systemic circulation, and it is usually expressed as a percentage. Another simple definition can be a percentage of administered drug that arrives in systemic circulation. But we should keep it in mind that this drug, it is absorbed from the site where it is administered and reaches in an unchanged form. So the significance is that it is used to determine the best route of drug administration. So in case you have, it can be used to compare the efficiency of a route of administration. In case I'm to give IM or IV, so I will compare the extent and rate of absorption of these two, which will be based on the bioavailability by IM and bioavailability by IV. So the best of those two, the one that has the best bioavailability, it will be the best route that I can take for administering. Bioavailability is evaluated by determining three aspects. One being the peak plasma concentration, in brackets the Cmax. So this is the maximum concentration of a drug obtained after administration of a single dose of that drug. Then also we need to determine the time at which the peak plasma concentration occurs, and this is initialized as Tmax. So this is the time that is required for us to achieve the peak concentration in simple terms, and this time will give us an indication of the rate of absorption. So if you know the total time and you know the concentration, the peak plasma concentration, so you can mathematically determine how much of the drug has been absorbed for a given minute or for a given hours or seconds. And usually this Tmax is given in hours or in minutes. Then the third factor is that we need to determine the area under the curve after a single dose. So this area under the curve, it will give us a measurement, or it is simply a measurement of the extent of the drug bioavailability. This is the bioavailability curve, and it is a plot of the amount of drug in blood, which is also known as the plasma concentration, against time. And it is simply showing us how the different factors that are used to evaluate bioavailability are varying, of which we have the Cmax, that's the peak plasma concentration of the drug in blood. Then we also have the area under the curve, which is showing us the overall drug exposure. Then we are also having the Tmax, the time that is taken to gain the Cmax, and it is simply, the curve is simply divided into absorption and then elimination. As well, we can appreciate some other factors like the half-life. That's the time where the drug has lost half of its maximum concentration, and then as the elimination goes on at another point, we can have the Cmin, which is the lowest concentration of the drug in blood. But simply we need to know that this curve, it is showing us the other three factors for evaluating bioavailability: the area under the curve, the peak plasma concentration, and then the time at which the peak plasma concentration occurs. Yes, initially I have explained to you that bioavailability, its significance is that it can be used to determine the best route of administration. And we should keep it in note that the bioavailability is never 100% for the oral route of administration because of some of the following reasons. One is the first pass metabolism. So this first pass metabolism is that metabolism that occurs before the drug will enter the general circulations. And this one occurs mainly in the intestines and in the liver. And this will reduce the amount of the drug that will be available, thus giving us a lower bioavailability. Then the second factor is that because of the poor water solubility and slow absorption. So when a drug cannot readily dissolve or penetrate the intestinal lumen, so this will mean that the time for absorption at the site of absorption may be insufficient, and therefore this drug will be lost, and this will result into a lower bioavailability. And as well, the efflux transport back into the intestinal lumen, whereby we find that certain drugs, after being absorbed again, they are taken out of the enterocytes back to the lumen. So these are simply some of those factors that will make bioavailability not 100% for the oral route. So now we shall move on to the second pharmacokinetic parameter, which is known as bioequivalence. So this is simply the relative bioavailability of two drugs. And these drugs are the innovator drug and the generic drug, which we are going to understand more in the next slides. So simply bioequivalence compares the bioavailability of two drugs. So we have seen what bioavailability is in the previous session. So it will compare their peak plasma concentration, the time taken to achieve this peak plasma concentration, and then also their area under the curve. So two products will be said to be bioequivalent if there is no statistically significant difference in their bioavailability, meaning if the difference in their bioavailability is very minimal, yes, that's when those two products will be said to be bioequivalent. So some of the products that are used in drugs, such as the excipients, which may be preservatives, and the buffers, which are the pH adjusters, can affect the absorption and metabolism, and they can be a source of some of the differences in these pharmacokinetic parameters, and they can make these two products non-bioequivalent. So the significance of bioequivalence is to evaluate if the generics conform, so the generics are the generic drugs, if they conform to the quality of the innovator drug, which is the original drug product. Now we shall understand the difference between an innovator drug and a generic drug. So an innovator drug is a patented drug that is protected from market competition. So the generic drug manufacturers, so this innovator drug is like the original drug. So it is the first drug that is created containing a specific active ingredient that is yet to receive approval for use, whereby its efficacy, the safety, and quality have been fully established. So it's like a new drug, an original drug, and this drug is whereby the generic drug manufacturers, they will come and they begin to replicate this drug if the patent has been removed. So these innovator drug manufacturers, they can sometimes hold the patents for so long, like for up to 20 years, while not releasing them. But after that time they want, they can release them, and then these generic drug manufacturers can use them for replicating the drug. And therefore, this makes the innovator drug a benchmark for safety and effectiveness of those other generic drugs. So the generic drug, it's a drug that is identical or that is bioequivalent to an innovator drug in the terms of dosage form, the strength, the quality, effectiveness, and the intended use. Now, when you look at the comparison between the innovator and the generic drugs, so here we have a table that is showing us this summary, whereby you have the parameters, the innovator drug, and then the generics. And we shall see that most of these are similar. For instance, the active ingredients, they will have the same. The safety and the efficacy, the quality, the performance and the standard, they are the same. But then the differences will come in with the cost. So this innovator drug is very expensive, and then the generic drugs, for them, they are somehow cheap. Then both of them, they receive the FDA inspection for manufacturing facilities. So FDA is the Food and Drug Authority. Then all of them will receive reviews from the FDA about the adverse reactions, and then they will receive reviews about the labeling. This labeling will only be to the innovator drug, but it will not be for the generic drug. And at the same time, the extensive research and development investments are more in the innovator drug, and then in the generic drug, there are no research and development investments. So expensive marketing and advertisement is more in the innovator drug other than the generic drug. The patent protection is with the innovator drug. The generics have no patent. And again, the FDA review to show the active ingredient, whether it is equivalent to an original, this one is not applicable for the innovator because already it is the original. But this review can be applicable to the generic drugs. Then the product development of these the innovator drugs can take for a minimum of 12 years, while for the generics, it is simply 2 to 4 years. So these tables here, they are simply just showing us some of these generic and then the branded drugs or the innovator drugs, and then their prices. You will find that these branded drugs or innovator drugs, they have escalated prices compared to the generics. For example, the paracetamol, you can see its price compared to its generic drug naproxen, then also amoxicillin. So you shall have a review of these tables and you will appreciate the difference in the pricing. Now we shall understand the third day pharmacokinetic parameter, the volume of distribution. So the volume of distribution, for it will measure the extent of drug distribution. And it is known as the hypothetical volume in liters in which a drug would be distributed, assuming its concentration is homogeneous. So this means that if the concentration in the tissues is identical to that in plasma. And the formula for volume of distribution is simply the dose over the initial plasma concentration after injection of an IV bolus. So an IV bolus is just a rapid infusion of the intravenous drug. That is the bolus. Then the dose is any amount of drug that is administered at any one time. For example, if I have 200 milligrams of drug that is administered IV, and then the initial plasma concentration is 10 milligrams per liter, my volume of distribution will be simply the dose, which is 200, over the initial plasma concentration, which is 20, and then my VD will be 20 liters. So in order to understand the volume of distribution and how best to apply it, we need to have two key notes to take home. The first one is that those drugs with a high volume of distribution, they have a low plasma concentration and therefore they will accumulate in tissues. So these are the drugs that will accumulate in the organs by either active transport or by specific binding to the tissue molecules, and this will give them the high VD. An example is meperidine, which is an opioid or narcotic analgesic. It is used in managing of severe pains. Then digoxin, which is used in managing heart failure and atrial fibrillation. Then the second point to take is that the drugs with a very low volume of distribution, usually less than 10 liters, are mainly confined to blood. That's the meaning. And this is because of their high degree of plasma protein binding. And the best examples of these drugs is warfarin, which is an anticoagulant, and the phenytoin, which is an anticonvulsant. Lastly, we shall understand the significance of volume of distribution. So, volume of distribution can be used to estimate the dose that is to be administered so as to achieve the desired concentration of the drug in plasma. Then it can also be used to estimate the concentration that will be achieved in blood after administering a given dose. So in simple terms, the smaller the volume of distribution, so therefore we shall have to give a lower dose to the animal, and therefore the plasma concentration will be higher. So such drugs that have a smaller volume of distribution should always be given in low amounts, because they will tend to accumulate in the plasma, and their continued accumulation might lead to toxicity in case you have given a higher dose. Thank you very much for listening. We shall catch up later in the upcoming videos.
Hello everyone, I'm Kato Lawrence Kanyike, and we are proceeding with the rate of pharmacokinetic processes. Well, to begin with, let us start with the plasma half-life. This is the time taken to remain with half the plasma concentration of the administered drug. For example, if you administer 100 milligrams of a drug per liter, the time taken for this 100 milligrams of the drug to reach 50 milligrams of the drug, or the time taken to remain with 50% of the drug, that is what we call the plasma half-life. Well, the significance of this is to determine the frequency of administration of a drug and the drug dosage interval. So usually this is dependent on the dose that is administered And for those drugs that obey zero order kinetics, an example is phenytoin. In overdose, it might not be the case. The half-life might change due to saturation of the elimination processes. For example, when those cells that are supposed to eliminate the drug, the cell excretory processes are saturated, the half-life may not be the same. Well, also catabolism can play a role in the half-life, catabolism or metabolism of these drugs within the liver, and those drugs that are bound strongly to plasma proteins, for example albumin, have a longer half-life. So these are some of the factors that will affect the half-life: the saturation, the catabolism, and the plasma protein binding. So it is also important to appreciate that the value of the plasma half-life is greatly affected by the clearance, and the clearance is the volume of the plasma that is cleared of a drug, and also the volume of distribution of the drug within the body. So the formula for half-life is 0.693, and this is a constant times the volume of distribution over the plasma clearance. So the half-life can be read from directly from the concentration versus time graph. From this graph, we see that if you administer 12.6 milligrams of a drug for the first day, the time taken for this 12.6 milligrams of a drug to become 6.3 milligrams of the drug, which is the half of the 12.6, that time is the half-life. In other words, for the time taken for the drug to become 50% in concentration. So as we explained in the previous slide, the plasma clearance is the volume of the blood cleared of a drug per unit time by either the kidney, the liver, or the GIT, but also the lungs can play a role in the clearance of the drugs. So the total plasma clearance is the sum of all clearance by all the routes. For the different routes are the kidney, the liver, the GIT, and the lungs for those gaseous drugs. So it is a constant for a particular drug in a specific patient, and the formula of the total plasma clearance is given by elimination rate of a drug in milligrams per minute over the plasma drug concentration in milligrams per mil. So an example here, if 400 micrograms of a drug is eliminated each minute and its plasma concentration is 2 micrograms per mil, so what is the total plasma clearance of that particular drug? So from our formula here, we just substituting the elimination rate of the drug, which is 400 micrograms, but they are saying each minute, so it is 400 micrograms per minute, and then the plasma drug concentration is the 2 milligrams per mil. So if you do the math, you will come up with 200 mils per minute, and that is our total plasma clearance. So if we proceed to renal clearance, this is the volume of the plasma that needs to be cleared per time by the kidneys, and it is given by the formula rate of the drug removal by the kidneys in milligrams per minute over the concentration of the drug in the renal artery, also in milligrams per mil. So this is a renal functional test, and it helps us to predict the state of the renal function in order to adjust the dosage of the drug so as to avoid toxicity to the nephrotic tissue. Let's proceed with the factors that affect the pharmacokinetic values. The first one is age. The renal and hepatic clearance decreases with age. Well, this is due to the deterioration of the renal function and the liver function, which cannot effectively excrete or clear the plasma of the drug. Then the second one is the renal impairment, as I explained before. This alters the clearance. In other words, renal impairment compromises the clearance of that particular drug, but as well, it increases the half-life of that drug because not much of the drug will be eliminated from the plasma. That's why I'm saying that the total clearance is proportional to the renal function. In other words, if the renal tissue is in good health condition, there will be effective clearance of the drug from the plasma. So another factor is the hepatic disease. Well, as explained before, this affects the clearance and also the half-life Well, here the half-life will increase because again not much of the drug will be eliminated from the body. For the cases of hepatic cirrhosis, there will be reduced drug metabolism. So this drug will accumulate within the body, and that could lead to toxicity, which is unwanted. Well, next is the drug interactions. If we have two drugs that compete for the same carrier, it's more likely that one of the drug will accumulate within the plasma, and that could lead to toxicity. Well, they might also compete for the active transport mechanisms or the metabolizing enzymes. Well, these metabolizing enzymes might become saturated if they have to metabolize two or more drugs, and so one or two of those drugs might accumulate within the body, and that could lead to toxicity. The next is the dose. For example, here phenytoin, as we said before, that phenytoin follows zero order kinetics. Therefore, it is dose dependent. Its half-life is dose dependent, whereby it can accumulate within the body, and the enzymes that are responsible for its metabolism have limited capacity to metabolize it. So this could be unwanted, and the phenytoin might accumulate within the body because its half-life is dose dependent, and that could lead to toxicity. Well, we move to the next, which is a plasma binding, protein binding. The major binding protein within the plasma is albumin, and those drugs that are strongly bound to albumin within the plasma have low distribution or volume of distribution and metabolism, as well as a low clearance. The next one is the first pass effect. Those drugs that need to first be delivered to the liver for metabolism before they are released into the general circulation. Well, this lowers their bioavailability, more so for those drugs that are orally administered. For example, these are supposed to utilize the enterohepatic circulation before they are released into the general circulation. For example, the lidocaine, which is a local anesthetic, propranolol, felodipine, and morphine, which is a narcotic analgesic. The next one is enzyme induction. Well, there are some drugs which stimulate the synthesis of high levels of enzymes from the liver, and those enzymes are supposed to metabolize those same drugs. Well, these drugs are called inducers, and they are also substrates to the enzymes that they induce, but also they may result in metabolism of other drugs. The common examples are barbiturates, diazepam, alcohol, and also phenytoin. So we should take caution for those that are excessive alcohol consumers. Well, this, for example, also these other drugs, diazepam and barbiturates, as the enzyme inducers, it will require you to administer the drug more often and continuously in order to replace the lost drug, and that can lead to toxicity. So the next one is the enterohepatic circulation. Well, this one prolongs the drug half-life. There are those drugs that utilize the enterohepatic circulation. They are delivered through the hepatic portal circulation, the hepatic portal vein to the liver, and within the liver they are conjugated to glucuronic acid, and then they are released. When they are released in the GIT, there is an enzyme known as beta-glucuronidase, which breaks that bond between the glucuronic acid and the drug, and so the drug molecule is able to circulate back to the liver via the hepatic portal vein. Well, that prolongs the half-life of that drug, and that can also lead to toxicity of that particular drug. Well, this sums up the rate of pharmacokinetic processes and the whole of the pharmacokinetics. Thanks for watching the Innovates YouTube channel.